Hello, my name is Carl Pillay. I'm a senior physician in the Division of Endocrinology and an associate director of the medicine residency program at Brigham and Women's Hospital. I'm also an assistant professor of medicine at Harvard Medical School. And today I will be going over questions for the Endocrine Board review. I have no disclosures. For case one, it's a 68-year-old man who is being treated with heparin for pulmonary embolism. 4 days after admission, he has sudden onset of severe abdominal and flank pain tenderness. He is found to be hypotensive. Labs show hyponatremia and hyperkalemia, and his hematocrit is 35% as compared to 40% at the time of admission. The most appropriate next step is to A, measure serum aldosterone, B, measure serum cortisol, C, measure serum cortisol before and after administration of cortrosyn or synthetic ACTH 1 to 24, D, measure urinary cortisol excretion, or E, start total fluid restriction at 1200 cc's per day. The right answer is C, measure serum cortisol before and after administration of cortrosyn or synthetic ACTH 1 to 24. So this patient has acute primary adrenal insufficiency. ACTH stimulation test is the best way to make this diagnosis. A random cortisol measurement without ACTH stimulation can be difficult to interpret. Decreased production of aldosterone does not necessarily indicate decreased production of cortisol, which is potentially life-threatening. Urinary cortisol excretion is not a reliable test for the diagnosis of adrenal insufficiency. Fluid restriction is not indicated in treatment of hyponatremia caused by adrenal insufficiency and can in fact exacerbate the patient's condition. So case two, a 52-year-old woman is brought to the office after falling and striking her abdomen on the edge of a chair. She has abdominal pain soon thereafter, but it has subsided. She is normotensive. Physical examination is unremarkable except for mild abdominal tenderness. CT of the abdomen reveals a 3 centimeter hypodense left adrenal mass with smooth borders. Serum electrolytes are normal. The most appropriate next step is to A, measure plasma metanephrines, B, fine needle aspiration of the mass, C, measure 8 a.m. serum cortisol following 1 milligram dexamethasone at midnight, D, both A and C, or E, repeat abdominal CT in 6 months. And the right answer is D, both A and C, measure plasma nephrines and measure 8 a.m. serum cortisol following a 1 milligram dexamethasone suppression test. Subclinical Cushing syndromes and pheochromocytoma are relatively common in patients with adrenal incidentalomas and must be ruled out. Fine needle aspiration of an adrenal mass can only detect a metastatic lesion and is not indicated in the patient without a known primary malignancy. A repeat CT to ensure that the nodule is not growing will be helpful, but it is not the first priority. Ruling out hormonal overproduction is more urgent. Case 3. A 24-year-old veterinary student has had symptoms of hypoglycemia before breakfast for several months. Laboratory studies early one morning revealed the following: serum glucose of 28 milligrams per deciliter, serum insulin of 65 microunits per mil, with the upper limit of normal being 15, serum C-peptide of 0.1 nanograms per mil, with the lower limit of normal being 0.5, and serum cortisol of 27 micrograms per deciliter, with the upper limit of normal being 25. The most likely cause of these results is A, adrenal insufficiency, B, non-islet cell tumor, C, insulinoma, D, surreptitious administration of insulin, or E, surreptitious ingestion of glyburide. The right answer is D, surreptitious administration of insulin. Elevated insulin and low C-peptide levels, as demonstrated in option D, are consistent with exogenous insulin administration. Adrenal insufficiency is ruled out by a normal cortisol level. Hypoglycemia caused by a non-islet cell tumor, or option B, is characterized by low insulin and elevated IGF-2 levels. Both an insulinoma and sulfonylurea overdose would result in elevated insulin as well as C-peptide levels. Case 4. A 32-year-old man comes to see you for follow-up of infertility after he was found to have a low sperm count and low testosterone. He is significantly taller than both of his parents. His testicles are small and firm. What is the best next step in the diagnostic workup? A. Measure serum follicle stimulating hormone, or FSH. B. Measure serum luteinizing hormone, or LH. C. Order a pituitary MRI. D. Measure serum prolactin levels. E. Examine his karyotype. And the right answer is E. Examine his karyotype. Based on the physical examination, the index of suspicion is high that the patient has Klinefelter syndrome or an extra X chromosome. While his syndrome is characterized by primary hypergonadism, leading to elevations of FSH and LH, neither test is diagnostic. Karyotype is the best way to make the diagnosis. Prolactin is not affected in Klinefelter syndrome, and there is no anatomic pituitary pathology that would be visible on the MRI. So case 5, a 61-year-old man comes to see you for the first time after recently moving to this area. He has type 2 diabetes and hemoglobin A1C is measured at 8.5%. He takes metformin 1,500 milligrams per day and insulin glargine 20 units at bedtime. His fasting glucose is in the 140 to 160 range. He was hospitalized 3 months ago for myocardial infarction. He has no history of heart failure, pancreatitis, chronic kidney disease, or medullary thyroid cancer. The best next step to treat his hyperglycemia is A. Start glipizide. B. Titrate glargine dose up, aiming for fasting glucose between 80 and 100 milligrams per deciliter. C. Start sitagliptin or Januvia. D. Start semaglutide or Ozempic. E. Increase metformin dose to 2,000 milligrams per day. And the right answer is D. Start semaglutide or Ozempic. This patient's in his early 60s with few complications of diabetes, therefore intensive glycemic control aiming for hemoglobin A1C less than 7% is warranted. All of the options listed will decrease his blood glucose levels. However, several, such as increasing the metformin or starting sitagliptin, are unlikely to decrease sufficiently to reach a hemoglobin A1C less than 7%. Even more importantly, he has established atherosclerotic cardiovascular disease. Therefore, a GLP-1 agonist like semaglutide or an SGLT2 inhibitor that have been shown to induce the risk of cardiovascular events are a better choice than other options such as increasing the glargine dose or starting glipizide that could adequately have improved his glucose levels. Case 6. A 44-year-old woman has had weakness and nervousness for several months. She also has noted occasional palpitations and has lost 5 pounds. Her pulse rate is 96 beats per minute. She has mild eyelid retraction and a slight tremor of her hands, but no thyroid enlargement or nodules. Her serum TSH is 0.01 microunits per mil, with the lower limits of normal being 0.5, and serum free thyroxine concentration is 2 nanograms per deciliter, with the upper limit of normal being 1.6. Her thyroid radioiodine uptake at 24 hours is 52%, with normal ranging between 15 and 35%, with a diffuse pattern. Pregnancy test is negative. The best next step is to A. Measure serum C-reactive protein. B. Begin a beta blocker. C. Administer I-131 radioiodine isotope. D. Start propylthiouracil. E. Start methimazole. The right answer is E. Start methimazole. This patient has mild Graves' disease. First-line treatment for Graves' disease are thionamides and specifically methimazole, or option E. Beta blockers can alleviate palpitations, tachycardia, and tremulousness, but do not lower thyroid hormone levels. In patients with more severe symptoms, beta blockers can be useful. Propylthiouracil, or option D, is associated with an increased risk of liver failure. Measurement of C-reactive protein levels do not assist in management of Graves' disease. Treatment with I-131 isotope usually leads to permanent hypothyroidism and is therefore not recommended as first-line choice in most cases. Case 7. A 32-year-old woman has had erratic menstrual periods since adolescence and amenorrhea for about 4 months. She has mild facial hirsutism for more than 10 years. She recently gained about 5 pounds and has had less energy than in the past. She takes no medications. She has mild facial hirsutism but no striae, central adiposity, hot flashes, or galactorrhea. Her prolactin is measured to be 52 nanograms per ml, with the upper limit to normal being 30, and the pregnancy test is negative. The most appropriate next step is to order A, ovarian ultrasonography, B, serum follicle stimulating hormone or FSH, C, pituitary MRI, D, serum testosterone, or E, serum TSH. And the right answer is serum TSH. Mild hyperprolactinemia associated with secondary amenorrhea can be due to primary hypothyroidism, as low free T4 stimulates increased thyrotropin-releasing hormone or TRH production from the hypothalamus, which stimulates secretion of both TSH and prolactin from the pituitary. Testosterone levels are not helpful in diagnosing the etiology of hyperprolactinemia. FSH will be suppressed in patients with hypothalamic amenorrhea. She does not have hot flashes, so premature ovarian insufficiency is unlikely, and it would be associated with and would not be associated with hyperprolactinemia. Hypothyroidism is more common than pituitary masses and should be ruled out before a pituitary MRI is considered. Case 8. A 68-year-old woman was found unresponsive at home by her daughter. In the emergency department, her temperature was 103.2 degrees Fahrenheit, oxygen saturation of 70% in room air, blood pressure 90/40, and heart rate of 115 beats per minute. When given oxygen, she was sleepy but arousable. Her thyroid exam was normal. She was hospitalized and treated with intravenous fluids and antibiotics. On day 2, thyroid function tests were drawn because of persistent sinus tachycardia. TSH was 0.5 microunits per mil, with the lower limit to normal being 0.5, and free thyroxine was 0.6 deciliter, with the lower limit to normal being 0.8. The best next step is A, pituitary MRI, B, thyroid ultrasound, C, thyroid I-123 scan and uptake, D, levothyroxine 100 micrograms daily, or E, reevaluate in 4 to 6 weeks. And the right answer is E, reevaluate in 4 to 6 weeks. This patient's thyroid function tests are consistent with both sick thyroid syndrome and secondary hypothyroidism. However, in the setting of a critical illness in a patient without a known pituitary lesion, sick thyroid syndrome is much more likely, and expectant management is recommended. Pituitary MRI would only be indicated if the patient's thyroid hormone levels do not normalize as she recovers from her illness. Thyroid ultrasound and radioiodine scan and uptake are not helpful in diagnosing the etiology of hypothyroidism. Levothyroxine supplementation has not been shown to be of benefit in patients with sick thyroid syndrome. Case 9. A 67-year-old woman comes for a follow-up visit 2 years after initiating alendronate or Fosamax for treatment of osteoporosis. She takes calcium 500 milligrams twice daily and vitamin D 800 units daily. She takes alendronate on Sunday mornings together with the rest of her medications. She walks a mile 5 days a week. Her 25-hydroxyvitamin D level is 32 nanograms per mils, which is normal. 2 years ago, her T-score on the left hip was minus 2.6. A week ago, follow-up bone densitometry showed a 6% decrease in the left hip, which was significant. The best next step is A, review proper administration of alendronate, B, double her calcium dose, C, double her vitamin D dose, D, switch to raloxifene or Evista, or E, switch to abandonate or Boniva. And the right answer is A, review proper administration of alendronate. So this patient has a failure of treatment with an oral bisphosphonate. She takes alendronate together with calcium, which can decrease bisphosphonate absorption. Therefore, the first step is to make sure calcium and alendronate are taken separately, or option A. She takes adequate calcium and vitamin D doses. Increasing these is unlikely to be of clinical benefit and could have adverse effects such as kidney stones. Neither raloxifene nor abandonate have been shown to reduce the risk of hip fractures or non-vertebral fractures, and thus are not ideal osteoporosis therapies for this patient. Case 10. A 62-year-old man comes for follow-up with diabetes. He used to be treated with metformin, 1,000 milligrams twice a day, and glipizide, 10 milligrams twice a day. But 2 years ago, glipizide was stopped and glargine or Lantus insulin was started. He now takes 30 units of glargine at night. He wakes up during the night from hypoglycemia 2 to 3 times a week, but his daytime glucose ranges between 150 to 220 milligrams per deciliter. His A1C is 7.5%. The best next step is A, stop glargine and restart glipizide. B, take glargine in the morning instead of at night. C, decrease glargine and add a rapidly acting insulin before every meal. D, stop glargine and start detamere or levemir insulin at night. Or E, ask him to eat a snack before going to bed. The right answer is C, decrease glargine and add a rapidly acting insulin before every meal. This patient has excessive basal insulin dose as evidenced by nocturnal hyperglycemia. His hyperglycemia is likely postprandial. Therefore, basal insulin dose should be decreased and prandial insulin added, as in option C. Replacing glargine with glipizide will further increase his daytime glucose levels. Administering glargine in the morning instead of at night is unlikely to make a difference, and replacing glargine with evening detamere will not reduce nocturnal hypoglycemia. Bedtime snacks will reduce nocturnal hyperglycemia but will not improve his overall glycemic control. Case 11. A 63-year-old woman is evaluated for severe hypertension resistant to treatment with 3 antihypertensive medications, which include an ACE inhibitors, calcium channel blocker, and hydrochlorothiazide. And she also has hyperkalemia. She's found to have serum aldosterone of 24 nanograms per deciliter, with the upper limit of normal being 21, and plasma renin activity of 0.2 nanograms per mil per hour, with the lower limit of normal being 0.6. Plasma norepinephrine and norepinephrine levels are normal. A 24-hour urine aldosterone level is 20 micrograms with urine sodium of 220 milliequivalents. Abdominal CT shows a 2 centimeter benign appearing nodule in the right adrenal gland. The best next step is A, abdominal MRI. B, repeat the CT in 6 months. C, refer to an experienced surgeon for right adrenalectomy. D, adrenal vein sampling. Or E, stop all antihypertensives and repeat biochemical test. And the right answer is D, adrenal vein sampling. The patient has primary aldosteronism. However, adrenal nodules are common in this age group, while excess aldosterone production could have a different source, such as bilateral adrenal hyperplasia. Therefore, confirmation of laterality of aldosterone production is the first step, and adrenalectomy is premature. Abdominal MRI will not provide any additional information. Deferral of definitive treatment of primary hyperaldosteronism is not appropriate. The diagnosis of primary hyperaldosteronism is definitive and no further biochemical workup is needed. Case 12. A 41-year-old man comes to your office complaining of progressive erectile dysfunction over the last several years. Evaluation shows testosterone of 1,200 picograms per mil, with the lower limit to normal being 1,800, and prolactin of 68 nanograms per mil, with the upper limit to normal being 23, confirmed by dilution. Pituitary MRI shows a 2.5 centimeter intracellular mass consistent with a pituitary adenoma. He denies headaches, his neurological examination is normal, and visual fields are intact. Morning cortisol is 12 micrograms per deciliter, IGF-1 is normal, and LH and FSH are low. The best next step is A, refer to a neurosurgeon. B, start bromocriptine or Parlodel. C, start cabergoline or Dostonex. D, start testosterone patch, or E, repeat pituitary MRI in 6 months. And the right answer is A, refer to a neurosurgeon. This patient has a non-secretory pituitary macroadenoma and should be referred to a neurosurgeon for resection to prevent further complications such as optic chiasm compression. Deferral treatment is not appropriate. Prolactin elevation is mild and thus due to pituitary stalk compression rather than production by the tumor. Consequently, treatment with bromocriptine or cabergoline is not the appropriate therapy. Gonadotropin production may recover after resection of the tumor, and therefore testosterone supplementation is premature. Case 13. A 56-year-old previously healthy woman reports intense flushing with her face turning purple. That's been going on for 6 months. She underwent menopause 4 years ago and was asymptomatic at the time. She also complains of frequent watery bowel movements. She takes no medications. She has one of the episodes during her visits, and her blood pressure falls to 102/61, down from 127/74. The best next step is A, magnetic resonance imaging of the brain, B, 24-hour urine collection for catecholamines and metanephrines, C, 24-hour urine collection for 5-hydroxyindoleacetic acid or 5-HIAA, D, 24-hour urine collection for tryptase, or E, start estrogen supplementation. And the right answer is C, 24-hour urine collection for 5-hydroxyindoleacetic acid or 5-HIAA. This woman's symptoms are most consistent with carcinoid syndrome. Therefore, 24-hour urine collections for 5-HIAA is the best way to confirm the diagnosis. Pituitary tumors do not typically cause flushing, and those pituitary MRI will not be helpful. Pheochromocytomas rarely cause flushing and are not usually associated with diarrhea. Serum, rather than urine, tryptase measurements can be used to diagnose systemic mastocytosis. New onset of flushing several years after the menopause is unlikely to be due to estrogen deficiency. Case 14. A 25-year-old man comes in for routine physical. He has craniopharyngioma resection at the age of 12 and has been taking levothyroxine ever since. His current dose is 112 micrograms daily. Blood tests show a TSH of 0.05 microunits per mil, with the lower limit to normal being 0.5, and free thyroxine of 0.7 nanograms per deciliter, with the lower limit to normal being 0.8. The best next step is A, decrease levothyroxine to 88 micrograms daily, B, increase levothyroxine to 125 micrograms daily, C, radioactive iodine uptake, D, pituitary MRI, E, reevaluate in 6 months. And the right answer is B, increase levothyroxine to 125 micrograms daily. This patient with a known pituitary lesion has been surgically resected has secondary hypothyroidism. In these circumstances, TSH is not a useful indicator for thyroid hormone adequacy. His free thyroxine levels are low, and his levothyroxine dose should be increased rather than decreased. Deferral treatment is not appropriate. As hyperthyroidism is not suspected, radioactive iodine uptake will not be useful. His pituitary disease is well established, and there is no reason to suspect any change that would be revealed by a pituitary MRI. Case 15. A 71-year-old man returns to see you for follow-up of type 2 diabetes. He also has hypercholesterolemia, stage 4 chronic kidney disease, heart failure, hypertension, osteoarthritis, remote history of pancreatic and bladder cancer, and family history of medullary thyroid cancer. His current medications include glipizide, 10 milligrams twice a day, and simvastatin, 20 milligrams at bedtime. His hemoglobin A1C is 8.2%, and fasting blood glucose ranges between 130 to 150 milligrams per deciliter. The best next step is to add the following medications to glipizide. A, metformin, 1,000 milligrams daily. B, liraglutide or Victoza, 0.6 milligrams subcutaneous daily. C, sitagliptin or Januvia, 100 milligrams daily. D, pioglitazone or Actos, 15 milligrams daily. E, glargine or Lantus insulin, 15 units subcutaneous at bedtime. And the right answer is E, glargine or Lantus insulin, 15 units subcutaneous at bedtime. In this patient, metformin and pioglitazone are contraindicated because of history of advanced kidney disease and heart failure, respectively. Liraglutide and sitagliptin are contraindicated because of the history of pancreatitis, and pioglitazone is also contraindicated because of the history of bladder cancer. Liraglutide is additional contraindicated because of family history of medullary thyroid cancer. Therefore, glargine insulin, or option E, is the only remaining treatment option. Case 16. A 65-year-old woman comes to see you as a new patient. She has type 2 diabetes, hypertension, and hypothyroidism. She takes metformin extended release 2,000 milligrams daily, glimepiride 4 milligrams daily, lisinopril 20 milligrams daily, and diltiazem extended release 240 milligrams daily. Her fasting lipid profile shows low density lipoprotein cholesterol of 120 milligrams per deciliter, high density lipoprotein cholesterol, or HDL, 51 milligrams per deciliter, and triglycerides of 167 milligrams per deciliter. The best next step is A, start ezetimibe or Cedia, 10 milligrams daily. B, start niacin extended release, 500 milligrams daily. C, start fenofibrate or Tricor, 145 milligrams daily. D, start simvastatin or Socor, 40 milligrams daily. Or E, start atorvastatin or Lipitor, 20 milligrams daily. The right answer is E, start atorvastatin or Lipitor, 20 milligrams daily. This woman needs to lower her LDL cholesterol, with guidelines recommending at least moderate intensity statin therapy for most patients with diabetes. Niacin and fenofibrate have not been unequivocally shown to decrease the incidence of cardiovascular events in patients with elevated cholesterol, while ezetimibe benefits are relatively weak. They're therefore not recommended as first-line treatment. Simvastatin, or option B, has significant drug-drug interactions with many calcium channel blockers and is contraindicated in doses greater than 10 milligrams daily in patients who take diltiazem. Consequently, atorvastatin, or option E, is the best treatment choice. Case 17. A 53-year-old woman comes to see you for follow-up of type 2 diabetes. She also has hypertension and obstructive sleep apnea. She has struggled with obesity for many years, and her current BMI is 37.5 kilograms per meter squared. She takes metformin 2,000 milligrams per day. Her A1C is 9.2%. Her blood pressure is well controlled in lisinopril 20 milligrams daily, amlodipine 10 milligrams daily, and hydrochlorothiazide 25 milligrams daily. She has tried multiple weight loss diets over the years, but has always regained the weight she loses. The best next step is A, start glipizide 10 milligrams daily. B, start glargine or Lantus insulin, 15 units at bedtime. C, recommend that she consider a bariatric procedure. D, start phentermine 30 milligrams daily. Or E, start empagliflozin or Jardiance 10 milligrams daily. The right answer is C, recommend that she consider a bariatric procedure. This woman needs to improve her glycemic control. She is obese and has several reversible complications of obesity. It would therefore be ideal for her to also lose weight. A bariatric procedure, such as option C, such as a Roux-en-Y gastric bypass or sleeve gastrectomy, will achieve both of these goals. Glipizide and glargine would lead to weight gain, whereas phentermine will achieve modest weight loss, but is only recommended for short-term use and will not improve her glucose control. Empagliflozin, or option E, will only result in modest weight loss and is unlikely to bring her A1C below 7%. Case 18. A 68-year-old woman was found to have primary hyperparathyroidism with mild hypercalcemia of 10.9 milligrams per deciliter, with the upper limits of normal being 10.5, and normal renal function. She is asymptomatic with no prior history of fractures or kidney stones. She has normal mineralization on DEXA with no evidence for vertebral fracture on spine imaging. What is the most appropriate next step? A, measure 24-hour urine calcium excretion. B, refer for parathyroidectomy. C, start tinacalcet. D, obtain a neck ultrasound. Or E, obtain a parathyroid scan. The right answer is A, measure 24-hour urine calcium excretion. So the initial evaluation of patients with asymptomatic primary hyperparathyroidism is focused on identifying patients who would benefit from parathyroidectomy. Indications for parathyroidectomy include age less than 50 years of age, serum calcium levels 1 milligrams per deciliter or more above the upper limits of normal, abnormal renal function, osteoporosis or the presence of asymptomatic vertebral fractures on imaging, and the presence of asymptomatic kidney stones or hypercalciuria with increased risk of nephrolithiasis based on 24-hour urine collection, which makes option A the right answer. Neck ultrasound and parathyroid scans are not required to identify candidates for surgical intervention. These are only done once the decision to proceed to parathyroidectomy has been made. Although tinacalcet can correct serum calcium levels, it does not typically normalize PTH values or protect against bone loss. Case 19. A 76-year-old woman who is taking biotin supplements is evaluated for depression, fatigue, and weight loss. Her serum TSH is undetectable, with free thyroxine concentrations of 2.1 nanograms per deciliter, with the upper limits of normal being 1.6. She does not have tremors, heat intolerance, or increased sweating. Her pulse is normal at 89 beats per minute, and she has a palpable 2-centimeter thyroid nodule. A thyroid scan shows a focal increase in radioiodine uptake from the isolated nodule, with suppression of uptake in the rest of the gland. The most appropriate next step is to A, start a beta blocker, B, administer I-131 radioiodine isotope, C, start levothyroxine, D, stop biotin and repeat labs in 1 week, E, measure triiodothyronine or T3, and the right answer is B, administer I-131 radioiodine isotope. This patient has apathetic hyperthyroidism due to a toxic thyroid adenoma, which can be treated with radioiodine ablation. Compared to typical hyperthyroidism, patients with apathetic hyperthyroidism have fewer features of sympathetic overactivity. Beta blockers would provide little benefit in the absence of tachycardia, and levothyroxine, or option C, would worsen the hyperthyroidism. Triiodothyronine, or T3, measurements are not indicated for the diagnosis or treatment of apathetic hyperthyroidism. Although biotin can interfere with the assays used in thyroid function tests, the thyroid scan indicates that there is indeed autonomous thyroid function. Case 20. A 62-year-old man with osteopenia develops low libido, sexual dysfunction, and weakness after resection of a large pituitary macroadenoma. He is found to have central hypogonadism with suppressed gonadotropins and low testosterone levels. He is started on testosterone injections. The best next step is to monitor A, serum testosterone levels, B, serum LH level, C, hematocrit, D, both A and C, or E, lower extremity ultrasound. And the right answer is D, both A and C, and that includes measurement of testosterone levels and hematocrit. Patients on testosterone replacement therapy should be monitored to ensure normalization of serum testosterone levels and avoidance of complications. Erythrocytosis is a common adverse effect of testosterone injections. Thus, measurements of both testosterone levels and the hematocrit, or option D, should be done several months after initiation of testosterone therapy. Monitoring of gonadotropin levels is not necessary in central hypergonadism. Although testosterone therapy increases the risk of venous thromboembolism, routine screening for thromboembolism is not recommended. So this concludes the questions, the board reviews. So good luck. And I have listed here some of the references that may be useful to you.